So we're going to look at the diagnostic evaluation of the kidney and urinary system. This is based on the USMLE content list of things that students should know about urinaries and collecting system. So we're going to review normal structures, infections, trauma, and congenital disorders that are listed on the items that medical students should be exposed to. What is this exam? A urogram, a nephrogram, a cystogram, a voiding cyst or urethrogram. You can either shout out or text your answer into the chat box or however you like. And I will continue to the next question when I have some responses. Okay, good. All right, so possibly nephrogram, and most of us, okay. What is this arrow pointing to? A muscle, an abscess, bone, spleen. So this is a CT scan. It's a contrast enhanced. You know that because the aorta has contrast in it. And here the abnormalities on the left side. A, okay. B, so someone thinks it's an abscess, okay. The patient has caseous necrosis, and the following imaging finding are what is the diagnosis. So what we see here is a CT, contrast enhanced CT. In the excretory phase, you see contrast in the collecting system. And so then this right kidney is not normal. In patients with caseous necrosis and on pathology, these imaging findings are concerning for, okay, B, TV. A patient has retinal hemangioblastomas and the following imaging findings. What is the underlying syndrome? This is an MRI of the abdomen, and we have contrast enhancement. Here's the abnormal kidney. We're looking at the arrows point to areas of masses within the kidney. So patient with concurrent retinal hemangioblastomas plus these kidney findings you're concerned about, okay? So Margaret thinks VHL, John, okay? What part of the kidney is this? So we have the cortex, the medulla, and then we have the collecting system that drains the urine. So what part of the kidney is this? A, renal pelvis, okay. Any other guesses? B, renal calyx, okay. So we'll go over that. So so this is the coronal image of the abdomen and pelvis. So what is this organ here? So it's the liver. Good. So the liver itself is abnormal. It's actually nodular, and then the spleen is huge, splenomegaly, and there's free fluid. But I show this because it shows the kidneys well. So the kidneys are in the retroperitoneum, in contrast to the peritoneum, which contains organs like the liver, spleen, parts of the stomach, and all the small bowel. The retroperitoneum contains kidneys, the ureters, and it's a separate compartment from the peritoneum. So in the kidney, we have different. So we have the cortex, and then it goes into the processing of the fluid and whatnot through the loop of Henle, and it comes down and gets concentrated, and then excreted into these little pointy structures, which are called fornices. And the fornices then drain into the calyx. So we have about 6 to 9 calyces per kidney. And then the calyces go through the infundibulum, which is this channel, and into the pelvis, and then goes down the ureter. The quiz question was, so that part of the kidney is the fornix, and that goes into the calyx, which goes into the infundibulum, and then the renal pelvis, which is the main area So the kidneys, we have, we say this in retrograde, and above the kidneys are the adrenal glands. And then we have the ureters that track down into the bladder. This is a excretory phase. So there's a special kind of sequence or a protocol called Urogram, which is optimized to look at the kidneys and the collecting system, which are the topics of this lecture. So when we give contrast through the IV contrast, it goes through the venous system, and then the contrast tracks the blood pool. So it goes into the arterial phase. Once it's in the arteries, it goes into the veins. So in the arterial phase, it's in the renal cortex, or right, and then eventually it'll go into the medulla. Contrast is excreted through the kidney. So here we see an arterial phase. You see that the medulla, they're not enhanced yet. So it comes peripherally and then it goes centrally to the medulla. Here you see that the medullas are more enhancing, and then eventually it gets excreted. The contrast is excreted through the collecting system. So now the contrast is here and it goes down into the ureter and bladder. This phase is called the excretory phase. And do you know how many minutes after injection we see the excretory phase, where in patients with normal renal function? When do we see contrast within the collecting system? Approximately. So the question is, medulla enhancing is arterial phase or venous? The medulla enhances in the venous phase, so we call that nephrographic phase. The cortical phase is the arterial phase because we see the cortex. Cortical phase and arterial phase are synonymous, and then the nephrographic phase and venous phase are synonymous. 7 minutes, yeah. So around 8 to 10 minutes, the contrast makes its way down into the collecting system. So the way we acquire a urogram is exactly like that. We actually do a split bolus. So we give one bolus of contrast, half amount, and then after 2 minutes, we give another dose through the IV. So that what happens is by the time we image, the initial contrast bolus is in the excretory phase, and then the second contrast injection is in the venous phase, nephrographic phase. And that way we only have to scan the patient one time instead of scanning them 2 times. So you cut the radiation in half. So we call it split bolus CT urogram. So we get the non-con, and then we give them contrast. We wait 2 minutes, we give another contrast bolus, and then we wait like 6 minutes, and then we scan so that the patient only gets 2 passes to the CT scan and not 3 times. So that's a split bolus CT urogram. So that's what CT urogram is. And it highlights the kidneys and the collecting system, the ureter, and the bladder. Oh, okay, sorry. So here is the anatomy of the kidney. We said right, cortex, medulla, and then it goes into the fornices, which are these little pointy tips, which then drains into the calyces, infundibulum, and then into the renal pelvis. So the CT urogram, this is what it looks like. We have a split bolus, right? So part of the contrast is in the collecting system and bladder, and the second bolus is in the parenchyma, so that we can see both at the same time and reduce exposure or having to repeat it twice. It can be either done with MRI or CT. This is an MRI, this is a CT. What you do, it depends. So CT is cheaper, but there's radiation. So if you have patients who are young, who are going to get multiple things like that, you want to get an MRI because there's no radiation. But both information mostly will give you very similar information. MRI takes a little longer. CT is very fast. Acquisition is like seconds. MRI takes anywhere from 20 to 30 minutes. But in terms of the image quality, you just get far superior image quality with MRI over CT. So you have to take the advantage. sort of take both into consideration and then decide what's best. If you're ever concerned about what you should do, you can reference ACR, American College of Radiology Appropriateness Criteria, and they have recommendations based specific to the clinical context. Urinary system also includes the urethra. So this is a retrograde urethrogram. So this evaluates the urethral anatomy. So here they put a small balloon catheter here. We pinch the tip of the penis, and then we inject the contrast to assess the urethra. This part of the urethra is not opacified because why? Yeah, so this is the prosthetic urethra. So it's going to be, the urethral lumen is going to be effaced by the pressure of the prostate, and that's normal. So this is the segments of the urethra. We have anterior and the posterior urethra. So the separation is the urogenital diaphragm, the muscular structure, and then this is and then you have, this is the bulbous and then the penile urethra. There's different ways to image the renal and collecting system. Ultrasound is a very powerful way to do so because number one, it's very cheap. And number two, there's no radiation. Number three, you have very good window because you can look at you have a nice window through the peritoneum, retroperitoneum, and then with the bladder, there's not gas in the way from bowel, so you have a beautiful window through the bladder. So ultrasound is very powerful at looking at the collecting system. And now that we have contrast-enhanced ultrasound, it's even more powerful because the limitations that we have with CT and MR, we sort of no longer have with ultrasound. For example, with CT urogram and MR urogram, your renal function has to be normal, right, or GFR greater than 30. If your GFR is less than 30, then you're not supposed to get contrast. But you can give contrast-enhanced ultrasound contrast, because ultrasound contrast is just CO2, so you just breathe it out. So it's advantageous for patients with renal failure. Of course, children, right? Always children. That's great, and and it's simple and sort of it's available. Of course, the limitation it depends on the operator. So with CT/MR, right, it doesn't matter who acquires images. You mostly get very standard, high-quality images. With ultrasound, it depends on the technologist and like the patient, body habitus. Patients who are heavier, ultrasound is very, very hard because you get acoustic attenuation from the really thick soft tissues. So advantages and disadvantages, but contrast-enhanced ultrasound is FDA approved for abdominal applications now. So it's an alternative modality for patients. We're moving on to infections. So here is a contrast-enhanced ultrasound, and what do you think? Is this normal, abnormal? What's abnormal about it, Samita? You're right. Good. Yeah, perfect. So there's bilateral striated nephrograms. So these little radial hypoattenuation in bilateral kidneys are what we're talking about. And normally it should be homogeneously enhancing. So you see this, and what are you going to think about? Pyelo. Good. So pyelonephritis is an infection of the upper tracts, and it usually stems from the lower tract, so cystitis. Patients who have diabetes, for some reason, are at an increased risk. Actually, they get a severe form of it called emphysematous pyelonephritis, where you get gas-forming infection. It's bad, severe, and this has to be treated because patients can rapidly deteriorate to become and have septic shock, urosepsis, and then because it's sort of like a pulmonary infection, you can get papillary necrosis, abscesses, and then in certain patient populations, it can go on to become chronic indolent pyelo. Those patients are typically patients with stones, renal stones, and so the stones act as a nidus for infection, as we see in this case. So here's a patient who has kidney stones here, and what it's in the renal pelvis. And what else do you see on this image? Hydro. Okay, good. So we have this is we have these hypodensities within the medulla. These are actually not hydro, although it looks like hydro. And the reason we know it's not hydro is because they're not communicating. It's hard to see with one static image, but these are sort of like intraparenchymal abscesses, sort of indolent infection. Although hydro can look like this, if we had more images, we can see that they're not communicating. Whereas patients with hydro, these lobulated hypodensities should be communicating. And what else? What do you think about the cortex? This is the normal cortex. It's very thin. So exactly, it's and what about the kidney size? Is it normal? This is the left side. That's normal. It's enlarged. So what's the diagnosis? Any guesses? So this is an example of xanthogranulomatous pyelonephritis, sort of end-stage chronic pyelo that happens in patients with staghorn stones. So this is why treating stones is important, because if you don't, then it acts as nidus for infection, and then patients can develop these indolent infections, which can then cause deterioration. So patients with XGP, how do you treat it? Any thoughts? Yeah, exactly. So they require nephrectomy. They don't respond to IV antibiotics. So you want to try to treat stones if possible. The upper tract. So there are complications of upper tract. So we see another case here. You have a renal stone and cortical thinning. And this is another case of XGP. And here, though, it's more complicated. We have this sort of thick-walled fluid collection in the posterior perirenal space that is consistent with abscess. Okay, so the question John has is, would polycystic kidney disease look similar on imaging? Polycystic kidney disease does not look similar on imaging. Polycystic kidney patients have simple cysts. So maybe I can just show you an example. They have sort of uniformly uniform cysts, and it doesn't look as dirty. The cysts are fluid attenuating because typically, so this is what polycystic kidney disease look like. The kidneys are enlarged from the multiple cysts, and patients they have sort of fluid attenuating cysts seen throughout both kidneys. So these are usually bilateral, not unilateral, and then you have interspersed normal parenchyma in between. And there's no stones. So the renal pelvis, the collecting system are normal. It's just the parenchyma that's abnormal. This is in contrast to XGP, where we don't see cysts. Instead of cysts, what you have is infection of the medulla, which makes it hypoenhancing because you have pus and bacteria and whatnot that's infiltrating the normal parenchyma. And then typically we have stones and tons of stranding because of the inflammatory reaction to the underlying infection. So here's another example of XGP. So you have a large staghorn stone, and then you have these hypodensity within the medulla from the indolent infection, and then you have a complicated, this toolbar is in the way, but it shows a similar thick-walled, rim-enhancing fluid collection in the posterior renal space, which is a perinephric abscess. Here is another example of upper tract infection. And so what do you see here on this coronal image? normal kidney, abnormal, and if it's abnormal, what's abnormal about it? Any guesses? Good. Yes. So this one is hydro because this is a better image. Do we know why this patient has hydro? Any stone in good? Yeah, perfect. Exactly. So there is hydronephrosis to this mid-ureter, and at the level of the mid-ureter, we see this stone. So it's an obstructing renal stone and complicated by severe hydronephrosis. So obstructing renal stone with urosepsis is like among the top leading causes of death worldwide, not in the States, but worldwide, because patients will rapidly deteriorate and become septic. So patients typically, what do you do? So patient comes into this and the imaging finding shows this. What do you do next? Any guesses? Nephrostomy and antibiotics. Good, yeah. So you need to decompress the urinary system. And the best way to decompress it is with a stent. You put a stent across this, and the urologists do that. It's the least invasive. And if you don't have stent, if the urologists are not available or for some reason patients can't get a stent, then you can do a PERC nephrostomy with image guidance. So we always prefer a double J stent first because you're not. It's just a lot less invasive, and you're going through natural orifice. But if you can't decompress it there, you could do a PERC nephrostomy. Let it heal, decompress the system so that you get rid of all the infection. There's a channel, and then the patient can be treated on an outpatient basis. So this is hydro, where we have it's just another axial image communicating inoculation. Sorry about that. This is an example of a PERC nephrostomy. PERC nephrostomies are done, as we mentioned, for decompression. It can also be done for access. So patients who have stones, large stones that will not pass on its own, can get a percutaneous nephrostomy placed by interventional radiology to give the urologist access so that they can treat the large burden of renal stone. So the way it's done under image guidance, typically ultrasound. Then you put a micropuncture needle. You get access, typically through a glide wire, and then we then dilate it. So you put a larger, like a 5 French catheter in, and then you do serial dilatation so that you have a nice track to then put a pigtail catheter in place that stays put. I'm showing you this because I want you to understand how a nephrostomy tube works. This is how most, if not all, pigtail catheter works, so that when you see it on the wards, you'll know how it works. So this is a pigtail catheter, and they call it pigtail because it when they pull the string here, it curls. The tip curls, and the curl keeps the pigtail from falling out. And then they tie it to the tip. So that's important to know and understand, because if you have a patient with a pigtail catheter, and let's say the abscess is drained and there's nothing there left, then you have to take it out. So the way you take out the pigtail catheter, there's 2 ways. Number one, you either release this. You have to release this knot because it's on traction. And you can do that by cutting the pigtail here, which releases that string. Or typically the string is tied to the cap, usually with a lock, and so you can unlock it. So you can either unlock it or cut this thing, and that releases the pigtail so that you can pull out the pigtail catheter. So here is an example of a patient who has a renal abscess right here, and here's the access needle, and then there's abnormal enhancement of that kidney, and then you can put the pigtail and then let it drain. So typically we say if abscess is about 3 centimeters or larger, it won't respond to IV antibiotics. So that's sort of like the rule of thumb is 3 centimeters. That will require drainage versus IV antibiotics. So here is a patient with caseous dilatation. There's also a stone, but the kidney is atrophied and the ureters themselves are abnormally enhancing and thick-walled. So one of the differential that we give in these is renal tuberculosis because you get urethral thickening and strictures, which we commonly see, sort of unique to TB. And TB causes infundibular strictures and narrowing, as you see here. You get narrowing. And of course, classically, we know about the caseous necrosis that we associate with TB. So tumors, their tumor distribution depends on age. So the most common tumors in children is a Wilms tumor. So this is an example of what a Wilms tumor looks like. This is the right kidney, and you see that there's this large mass, and this abnormality actually is purely involving the kidney, and it has mass effect. It's displacing the aorta and the IVC ipsilaterally. So patients typically present with palpable mass, hematuria, and flank pain, and it's related to this genetic defect in the Wnt1/2 suppressor gene, and it can be part of syndrome, the Wagner syndrome, or the Beckwith-Wiedemann syndrome. In adults, however, the most common type of renal cancer is clear cell carcinoma. And so here is a CT where we see this mass in the upper pole, and then an MRI where we see this mass in the upper pole of the left kidney. So what else do you see? Well, this is a GIF, so I can't pause it, but renal cancers are notorious for venous invasion. So what do you see here on the MR? Any guesses? Engorged renal vein. Yeah. So the Sumita pointed out the renal vein is enlarged, and so this is contrast enhanced MR. So if you look at the renal vein, is it enhancing or is it non-enhancing? Non-enhancing, enhancing. Okay, we're 50-50. So this is enhancing. You can use the comparable renal parenchyma or the liver to assess that, and it looks like it's the same signal intensity right here as the enhancing liver and the renal parenchyma. So this is how you differentiate a tumor thrombus from a bland thrombus. So a tumor thrombus is vascular, and it's just the tumor crawling into the IVC renal vein and up the IVC. In contrast, bland tumor is just a clot, so clots won't enhance. So here we have a T3 tumor. This is due to chromosome, like a genetic defect in chromosome 3, and patients, it's like an underlying problem that inhibits hypoxia-inducible factor. So then it causes a hypoxemic state, and then you get marked angiogenesis. So patients now can get either surgery or ablation if they have localized tumor mass. If it's locally invasive or metastatic, then they need to get usually different types of treatment. But renal cancer is actually really quite remarkable because it's relatively indolent. So even patients with metastases, for example, oligometastases like lung, if it's a small volume, they'll go ahead and do metastectomy or ablation, and patients do incredibly well just by having stage 4 disease. Here's a patient who has a mid-pole renal tumor cancer, and here is a percutaneous ablation. So this is done by interventional radiology. Under CT and ultrasound guidance, they put the ablation tip in there, and the tip of this RF ablation probe, it heats up. It burns, and then it basically kills the tumor. and it's done under imaging guidance, and so you can assess for residual tumor, complete, efficacy, things like that. And the nice thing about renal ablation is that it's an outpatient procedure. So patients come in, get the procedure done, and then they walk, they basically leave the hospital. In contrast to partial nephrectomy, which requires, a hospitalization, and it's a little bit more invasive. Couldn't that cause necrosis? So yes, it's going to, the tissue will be dead. The tumor will be dead. But because it's a sterile procedure, it's not infected. So the body will just wall it off, and then over time it gets smaller and smaller and smaller. Eventually it just becomes a scar once the body resorbs the dead coagulated tissue. Even though RCC, clear cell RCC is the most common, a second common tumor is oncocytoma, which is benign. So that's hard to differentiate from clear cell renal cell carcinoma. So typically, if you are concerned or patients are a little older and are a poor surgical candidate, then you want to do a biopsy to differentiate. There used to be an old teaching saying like you should avoid renal mass biopsy for concerns about seeding. It's a myth. Multiple studies have shown over and over again that it's not based on any data, and the AUA, American Urology Association, recommends renal mass biopsies in certain cases where it'll make a difference to the patients. Oncocytomas are benign, so they don't need treatment. So it's important to differentiate that if possible, because you can spare the patient unnecessary treatment. Neoplastic syndromes, the one that you should probably know about is VHL and TS. VHL is a defect in chromosome 3, and then they get a combination of RCCs, pancreatic tumors, hemangioblastomas in the retina or in the spine, and it's due to this defect, HIF1 alpha. And then Burghoff-Dubé is less common, and then TS, you should just know because we do see it, but everything they have is benign. They have lymphangiomyoma, LAM, in the lungs, angiomyoma lipomas in the kidneys, and they get, so there's like these tumors in the brain that causes seizures. Even though it's benign, the problem is that if the AMLs get large enough, they can bleed. Tumors can lead to seizures, so there's all these other problems that can result from the syndrome. So here are examples of manifestations of VHL. This is a retinal hemangioblastoma. It's a benign renal tumor of vascular origin, and so this is what it looks like. Here is the image that we saw initially in the quiz. We have multiple renal enhancing masses, most likely clear cell, although other subtypes can occur concurrently. And then here we have multiple pancreatic lesions. Here is a cerebellar hemangioblastoma. These are manifestations, so this of BHD, Burghoff-Dubé, which is another much less common syndrome. So you don't worry about it, but you get pulmonary cysts here. They get these little skin lesions, and then you get oncocytomas. Tuberous sclerosis is more common, and you might see it. And so patients get these little tubers, and then so the problem is that these can act as foci for seizures. They're benign, but they can cause seizure activity. They get these like skin angiofibromas. They get these pulmonary cysts in the lungs. They call this lymphangiomyoma, LAM. And then the kidneys here, there's AMLs, angiomyolipomas. And this is important because when they get really big, they can hemorrhage. Even though they're benign, they can lead to significant bleeding and possible death. So if it's greater than 4 centimeters, interventional radiology, they can go in and then coil embolize the AML, and then preemptively, prevent hemorrhage. Moving on to more of the collecting system tumors. We talked about kidney cancers. Now we're going to talk about urothelial tumors. Urothelial tumors are usually transitional cell carcinomas, and it can happen anywhere along the urothelial lining. So here we see a lesion that arises from the upper pole tract, and it goes into the kidney. So some people might think this is a kidney mass, but if an astute radiologist or provider will recognize that if it's a central mass like this, one of the differential diagnoses has to be transitional cell carcinoma, TCC. And the reason is because of how you treat TCC compared to RCC. Does anyone know how TCC, upper tract TCC is treated? Compared to RCC? Chemo. If it's metastatic, we do chemotherapy, but let's assume this is a localized tumor. Radiation. No, typically, so with RCC, they either do a partial nephrectomy, ablation, or if it's a really large tumor, they'll do a radical nephrectomy. In contrast, for TCC, they do a nephroureterectomy. So they take out the kidney plus the entire ureter, all the way to the ureter orifice. And that's because the thinking is that if this is involved, then they're going to get satellite tumors elsewhere. So they strip the entire collecting system. So it's a completely different procedure, or operation, excuse me. So this is why it's important to have proper diagnosis before surgery. I've seen a case of a patient who had a tumor that looked just like this, and it was an outside CT. The urologist saw it and automatically thought it was an RCC. It wasn't reviewed, and then the patient did a nephrectomy. The pathology came back as TCC, so the patient had to get a second operation to remove the remaining ureter. So a differential diagnosis for central lesions like this is TCC, and it's not uncommon. So patients have painless hematuria. Smoking is probably the most important risk factor, and it's a satellite effect, meaning that patients who have it have to be on serial surveillance because they can get not recurrence, but satellite lesions elsewhere, because presumably it's a field effect. The carcinogens, all the urothelium is exposed, not just that area, for example. So this is the excretory phase of the urogram, and what we see is that the normal calyces, you see this filling defect within it. And so this is what TCC look like, that it causes a filling defect. And here we see a filling defect within the mid-distal ureter. So this is the urographic phase, the excretory phase, so you can see these beautifully with CT urogram. So that's why it's a study of choice for patients with painless hematuria. And here is the bladder. So what do you guys think about? Is that a normal looking bladder or abnormal? What's abnormal about it if it's not normal? A mass, yeah. So there's a mass. So here's the bladder. Exactly. There's an enhancing mass, and it's causing a filling defect. So this is a CT, and here's an MRI. MRI, you just get just really incredible soft tissue resolution, so you can see the stalk of that papillary TCC. So this is what it looks like, these papillary fronds on cystoscopy, and they typically will just shave it off and assess for muscular invasion. If there's no muscular invasions, patients just get that resected to URBT. If there is muscle invasion, then the patients will require cystectomy. Okay, moving on to trauma. So questions. So Sumita asked why. Sorry, I missed that question. What was the why for? Oh, okay, great. So trauma and mechanical disorders. These are the things on that USMLE content list, so these are just copy and pasted from there. Bladder rupture. So bladder rupture can happen in trauma. Patients typically have other pelvic traumas if you have bladder rupture. So typically patients who present with bladder rupture, it's a pretty high velocity MVC, and so they'll have concurrent pelvic fractures and other problems. So bladder rupture can the location of the bladder allows it to either rupture in the intraperitoneal or in the extraperitoneal space. The peritoneal, depending on where rupture. So if it's extraperitoneal, then it goes into the space of Retzius, which is the space between the pubic symphysis and the anterior bladder wall. If it's intraperitoneal, then it's going to sort of go around the bowel. And that's important because the common teaching is that intraperitoneal bleed need to be repaired, whereas extraperitoneal bleed or rupture don't have to be repaired. They just get treated conservatively with Foley catheter. So that's the difference between extraperitoneal and intraperitoneal. Other traumas that can occur to the kidney and the collecting system, you can get renal injuries, and we determine the severity of it. So it could just be a simple laceration like this, where you end with a perinephric hematoma, or it can be almost like an avulsion. So you can compromise the vascular pedicle and then essentially cause a avulsed kidney or some type of even shattered kidney. Nowadays, we're leaning towards conservative therapy. So unless it's a category 3 lesion where you have pedicle compromise or avulsion, these are typically managed conservatively with watchful waiting. In some cases, if there is bleeding and there's active extravasation, interventional radiologists can go in and then coil embolize the area of active extrav. So trauma, we do. So the other things that can get injured is the ureter itself can get injured. So with urethral injury, we need the excretory phase. If you're concerned about urethral injury, you can obtain a urographic phase. And in fact, in some trauma centers, patients routinely get the excretory phase. So with trauma, we only usually just get the venous phase of the abdomen and pelvis. But some institutions are getting really creative. And so remember I told you about the split bolus that we do for Urogram, where we give 2 separate bolus timing and then acquire it at one time. Some trauma centers are doing 3 bolus. So it's instead of 2 bolus, it's 3 bolus. So that they inject contrast once, and then they do it again, and then a third one later, so that they get both an arterial, a venous, and an excretory phase all at the same time, acquired at the same time. That way, they can rule out arterial bleed on the arterial phase. They can look at parenchymal injury on the venous phase, and then they can look at urethral injuries on the excretory phase. So you can get really creative now because the scanners are so fast and it's so good. But with that protocol, basically you have to wait essentially 10 minutes, right? Because you're waiting for the excretory phase. In contrast to the venous phase, which is done within a minute and a half. So you probably can't do it for all patients because if they're unstable, they probably should get treated and managed faster sooner rather than later. So the jury's still out in terms of what protocol is the best, but some trauma centers are doing that already. All right, keep going on to mechanical and trauma disorders. Patients, this is an MRI, and what do you think about the MRI of the bladder? Normal looking bladder. Yeah, what else? So it's enlarged. What else? What about the morphology? Yeah, it's regular, and I mean we don't see it on this image, but sometimes you get trabeculations. So what is this? When do we see this kind of bladder appearance? Or what does it suggest? Yeah, so it suggests obstruction, right? So it can, from BPH, for example, could be one example of obstruction, or it could be neurogenic, like the patient has, trauma and they had a spinal cord transection. Now they have neurogenic bladder because they just have abnormal, nerve function. It could be mechanical from BPH, from tumors. It could be so a lot of different causes, but you basically have an obstructed or like a very large dilated bladder, and of course you would have to figure out what the underlying cause is. The causes you can get right: neurogenic, multiple sclerosis, Parkinson's, cauda equina, and paralytic syndrome, and stroke. So this is an example of a cystogram. So a cystogram is a radiograph here. This is in contrast to MR, and then we inject contrast into the Foley catheter and then fill the bladder. This helps us assess the bladder morphology, the capacity, and the function. So what we see here on the cystogram is a very similar finding: large bladder capacity with trabeculations, consistent with neurogenic bladder. Trauma and mechanical disorders. So another cause of a dilated bladder is posterior urethral valve. This is actually a misnomer. It's not a valve; it's a membrane, and the membrane is in the urethra. So here is VCUG, vesical urethrogram. So you look at the bladder plus the urethra, and what you see is that it's dilated up until this point here, and it's due to this little membrane that's causing obstruction, so that you have obstruction of flow. So these are usually diagnosed prenatally in male fetuses because they can get severe hydronephrosis and reflux bilaterally. The diagnosis is important because otherwise you can cause bilateral kidney failure. The treatment itself is very simple. They take a cystoscope, a urethroskop, and then they just ablate the membrane so that you have normal channel and normal flow. So it's more recognizing it rather than the actual treatment is pretty simple. Trauma and mechanical disorders. So we're going to talk more about mechanical disorders. So, ultrasound is very, very good for the kidneys, especially as initial workup, and it's considered sort of the first line for patients who come in with AKI. So AKI we know can be pre, intra, or post-renal, and so we get an ultrasound to exclude a post-renal cause. So what do you think about this ultrasound? So this is the kidney, this is the ureter here, and then this is more south at the bladder. What do you think? Normal, abnormal, it's dilated, good. So there's hydronephrosis. So good. So the renal pelvis is there's hydronephrosis. In addition, there's hydroureter, right? So the ureter is also dilated. So it's hydroureteral nephrosis. And from these images, can we tell what it is from? Do we have an etiology? Stone in the urethra. There is a stone. It's right here. So it's at good. So there's a stone here, and it's at the UVJ, ureterovesical junction. This is the trigonus for the ureteral orifice inserts. So yes. So John has a question. What's the significance of the flow? This can also be from a vessel, because a vessel is also hypoechoic and tubular, and the flow tells you that this is the iliacs posteriorly, so this is the ureter anteriorly. It helps you identify the structure with more confidence. So if there was flow within this structure, then it wouldn't be a ureter, because there's no blood flow in the ureter, just urinary flow. So and since we know the iliacs are here, you know that this is right near the pelvis by the iliac crest, because that's where the ureter goes down. Trauma, mechanical. Okay, so more mechanical stuff. So here is an example of a pelvic MRI in a man. So we have axial, frontal, sagittal. Here we see the Foley catheter. And what do you think about this MRI? Normal looking MRI, abnormal. And why is the Foley there? Prostate looks big. Yeah, exactly. So the prostate is markedly enlarged. There's two zones in the prostate. There's a peripheral zone and the transition zone. And as men get older, the transition zone can become hyperplastic. They get BPH nodules, and so they can get really big and then cause obstruction because the urethra is right here, is like central. So this patient has a Foley catheter because the patient is probably obstructed, so they're decompressing the system. Good. So it's a major cause of bladder outlet obstruction in men, primarily just because of its prevalence and our aging population. In contrast, we can have overflow incontinence. So there's different phases of urinary dysfunction. So here we have obstruction. What happens is with obstruction, eventually it can cause irritation of the bladder, or if it gets really, so there's different kinds of problems that can occur from chronic obstruction. And one that happens is called detrusor underactivity. That happens because you just have chronically obstructed, so then the entire bladder just becomes really big and distended, and so then at some point it gets so big that you start to leak because it's just overfilling. And so patients who are, they void, but they have a lot of residual within the bladder, so then they need to self-cath themselves, or in some cases they can go into acute renal retention, and they can get AKI because of hydronephrosis. So those are important things to consider. In addition, maybe more importantly, to quality of life, right? Patients are like have urinary frequency, urgency. I mean, those things really affect quality of life. So there's different treatment. There's medications. There's also TURP, transurethral resection of the prostate, and then there's an interventional procedure called PAE, prostate artery embolization, where they embolize the lesion. So obstruction is important because it can lead to post-renal AKI, and that happens, you get bilateral obstruction. Okay, so moving on. So this is, what kind of study is this? So we see the urethra plus the bladder. So this is a, well, yeah, so a cystogram is one part of the study. Good, perfect, yeah. So it's a cystourethrogram. So they, and what do you see? What do you see? Normal, abnormal? There's a narrowing. Where? Urethral tear. Yeah, there's something here, right? There's this contrast. So the normal urethra contour is here, but then there's contrast, opacification, lobulated contrast, opacification. I mean, we're sort of limited, but this is what a diverticulum looks like. So you can get diverticulosis, diverticulum elsewhere. So there's a urethral diverticulum. And here's an MRI example of a urethral diverticulum. So it's a sagittal. This is a woman because there's a uterus. And you have this fluid collection in the region of the urethra. We don't have the axial, but this is a urethral diverticulum. Urethral diverticulums are important because you get urinary stasis, and anytime you have stasis, that predisposes you to infections that can then lead to chronic inflammation, and patients can get cancer. So patients with diverticulum can be treated with surgical resection. Okay, good. So keeping moving on. So other mechanical disorders that we can see. So what is this study? This one, we don't really do this anymore, but this is a pilogram. We don't do this anymore because now we have CT urogram, and so we can generate these images. But this is done by urology. So you see the little cystoscope, urethroscope, and then they inject contrast. So we see that the proximal collecting system is dilated, but here is, what do you think? This is like, does this look like the rest of the ureter? stricture, yeah, it's a long segment stricture, right? So that's another type of mechanical disorder. Looking at this, we can't say what caused it, but the patient may have had radiation, maybe may have had prior infection, inflammation. So the actual cause we don't know, but there's a long segment stricture which has led to hydronephrosis. So they can resect it and then try to do a urethral implant, or try to correct the stricture with by dilatation, serial dilatation. Here, what kind of study is this? So we see the urethra anatomy very well, and the study is called Urethrogram, RUG, yeah, Retrograde Urethrogram, RUG. And what do you see? Normal, abnormal. Stricture, good. So there's a focal high-grade stricture in the region of, it's probably at the penile junction. So this can cause a lot of problems when the patient urinates. So then they can reconstruct it. They usually resect it and then put a buccal mucosa here to retubularize the urethra. But this can be from infection, in some cases trauma, in some cases tumors, but less commonly. Usually infections, gonococcal, chlamydia infections. More mechanical disorders. So here we're looking at a dynamic MRI. So this is a sagittal MRI. So the spine is back here. We have the anterior, middle, and posterior compartment. So anterior compartment contains the bladder. Middle compartment contains the uterus and vagina, and the posterior compartment contains the rectum. And it's dynamic. So patient is at rest, and then the patient is then asked to Valsalva. And this is what we see with stress. So what do you see? Is that normal response to Valsalva? So this is the bladder. This is the urethra in a woman. Prolapse, good. Yeah, exactly. So we have, and what do you call prolapse of the bladder? Cholecystocele. Good, perfect. So here we see the prolapse, and you can characterize the severity of prolapse, right? So here we only see an anterior compartment prolapse. The urethra, so this is the bladder neck as it goes into the urethra. So the angulation is also abnormal. So we call this urethral hypermobility, and this can lead to incontinence, problems with quality of life. So they can correct this actually surgically. So here is an example of an anterior compartment prolapse, but any compartments or all can prolapse, and you can do a urodynamic or a dynamic pelvic exam to assess that and diagnose the patient's condition. And this is the normal rest stress. So normal is like this, and stress when they Valsalva, nothing should come down in normal patients. And here we see that the bladder is prolapsing. Okay, and that can cause stress urinary incontinence. So stress urinary incontinence, patients, when they are sneezing or coughing, they'll leak urine, and one causes urethral hypermobility. We saw that. That's basically when the urethra angulates like this, right? So the urethra should just be pointing up and down like this. But here, urethra is pointing this way instead of vertical. So it's hypermobile. And that can cause stress urinary incontinence. All of these things can be diagnosed with imaging. And any kind of increased estrogen level increases that condition, as well as vaginal delivery, prostate surgery. And you can do a bladder stress test. Patients are commonly treated first with biofeedback and exercises, Kegel exercises, and they can, if it's severe enough or affects their quality of life, they can get an MRI to then really characterize their problems and then maybe get surgical correction. Okay, more congenital disorders. So here is, oh, sorry, we're moving on to congenital disorders now. But here we have, what do we have here? What kind of study is this? Parallelogram. So it's a retrograde, yeah, cystogram. So here, the cystogram, normally if you feel the bladder, you shouldn't see the ureters or the renal calyces. But here, the bladder fills and you see both. So this is called reflux. And it's severe because the renal calyces are starting to get blunted. You lose the normal fornices and stuff like that. So this is bilateral reflux, and it's a child. If you look at the bone, it looks immature, and you get the epiphyses of the femoral head. So this is a child, and so you have to sort of find out what is causing the. So if it's bilateral, one common cause could be a posterior urethral valve that we saw before, but there are different causes. Here is an example of the hydra that we see on ultrasound, and here, this is something that pediatric radiologists are doing a lot more now. So this is how you diagnose reflux, but this is radiation, and children in general are a lot more sensitive to radiation than adults. So pediatric radiologists, they've started now doing contrast-enhanced ultrasound to diagnose reflux. So it's an ultrasound, and then they inject IV CO2, DEFINITY. There's different types of ultrasound contrast agents, but and then it goes into, remember we said, right? It goes into the cortical system, venous system, and then it comes down the collecting system. Same way, right? So we can do that now with ultrasound. So, and that's what we have here. So here's a kidney, and the contrast is coming down the collecting system and into the bladder. So here you can diagnose reflux using contrast-enhanced ultrasound. And where I am, this is how they're now doing it over this VCUG, because this has no radiation, right? You want to spare radiation for the children if possible. Okay, congenital disorders. So these are just some congenital anomalies that can develop in patients. This is called so we have 2 renal pelvises and 2 ureters. What is that called? Any thoughts? So normally we should just have 1, but here we see 2. So this is called a duplicated collecting system. Sorry, there's no creative words for it, but it's a duplex collecting system. And most cases it's uncomplicated, but in some cases it can become complicated because of the nature of it. So one, for example, problem could be you get upper pole hydronephrosis, and that can happen from like a ureteral seal, which it has been described in duplex collecting system. So the upper moiety is obstructed and the lower moiety is fine. So when you have obstruction, you can get hydro and you can get infection. Here we see a stone that's obstructing in one of the collecting system. And here we see, well, this is actually bilateral. It's not a duplicated collecting system. It's normal collecting system, but bilateral ureters are dilated, and it narrows, tapers distally at the ureteral orifice. So this is just congenitally mega ureter. So it's just big ureters congenitally. Other congenital disorders, you can get horseshoe kidney. So the lower pole, they call it an isthmus. It's fused. They still have normal renal function, but people with solitary kidneys, they have to be careful because they can get injury to that really easily. The location of it also predisposes them to kidney stones and infection, and then rarely cancer. So it's below the SMA, and so you have fusion of the isthmus here, which is what we see with that congenital anomaly. Horseshoe. Was there a question? Okay. So here is another congenital anomaly called renal hypoplasia. So the kidney is just small. And then here is a kidney that's normal, but it has a big cyst, renal cyst, which is not, it's a simple cyst. Here, patients can have solitary kidneys, so they can just be born with one kidney. Patients who have solitary kidneys often have concurrent uterine Müllerian anomalies as well, like septate uterus, bicornea, things like that. Here we have dysplasia, so the kidney is dysplastic, so they're usually non-functioning, and this is a congenital disorder. So going back to our quiz questions, this exam is what? Have I lost you guys? Everyone? Good. So it's a CT urogram, or MR urogram, good. And this is what? Abscess, muscle, bone, spleen. Good. And what is this? Okay, I think most of you guys got this right. It was TV. And then this one is what? Good, VHL. And then this one is what part of the kidney? D? Good. Hornets. And this one is, oh, that's it. Okay, what questions do you guys have?